Good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System and Executive Vice Chancellor for the University of Kansas Medical Center. This is Open Mics with Dr. Stites, and that's a long sentence. Lester McKinzy was working construction on his feet every day, then suddenly he couldn't walk at all. Today we are talking about a rare, complex disorder and the breakthrough that helped Lester get back on his feet. And might I say, as we'll talk about in a minute, to work out at 4:30 every morning. That's amazing to me. But first we have this morning is Dr. Mario Castro, the Division Chief of Pulmonary Critical Care and Sleep Medicine and the KU Medical Center Vice Chair for Clinical and Translational Research. Dr. Castro, you're here to talk about the Lung Health Cohort Research Study. The goal is to fundamentally change how we prevent, diagnose, and treat lung disease for people in America and around the world. And just to say it out loud, you had a major role in our COVID studies. You were actually one of our studies led the nation in enrollment. So I'm guessing this is going to be a pretty big deal. Tell us a little bit about the study.
Well, Steve, the Lung Health Study is a groundbreaking study for us. Many of us heard about how we've learned about heart disease in terms of the Framingham study. This is very similar in that we're trying to understand the early determinants of lung disease. So we're enrolling people that are 25 to 35, healthy.
So I'm out on that one, I'm hearing.
For sure.
Oh, for sure. You didn't have to add the for sure.
But we're doing the latest kind of technology to understand how they're impacted. So we're doing things like doing CAT scans or imaging of the lungs to understand how the lungs are now and how they change over time. But we're also doing things like capturing environmental information from satellites, what we are being exposed to. And of course, nowadays, as we all know, we're all being exposed, our younger folks are being exposed to things like vaping. We don't understand what the long-term health effects are in the lungs. And we're capturing information about patients' diets or people's diets and what their intake is. So we can understand, hopefully, over time, how these things change the lungs, how do they change our trajectory, and why do some patients that smoke develop lung disease and others don't? We still don't understand that pivotal question.
Don't smoke. That's not an excuse. Don't smoke. Go ahead.
That's right. So we're about 3/4 of the way through enrollment. So I'm happy to be back and talking about this study because we just hit our 3,100th patient in there. So we were excited. But we got this last stretch to go. And we're very excited about completing this and completing it in a way that is appropriate and that we have representation of all the different facets of the United States and that we're able to understand how this lung health is leading to lung disease. How does these exposures on our body lead to lung disease?
That is fascinating. So who's the ideal participant for these last home stretch of patients you need to go? And I take it is that a national number or is that a local number?
National number is 3,100. We've enrolled now almost 300 patients here, participants
we're
here.
Again, hitting above our batting average.
Yes, we're in the top 2 in the country. What we are looking for are really somebody that is 25 to 35 and does not have significant lung disease or significant heart disease. Most people in that age range don't. But we want to really study the development of that lung disease or heart disease, and so we want to understand what happens early in that. So that's really the only major exclusion criteria, and we want you to participate. That's the key, and really I think we're going to put up here a number here of how to contact us, and you'll be able to reach out to Jessica. Jessie will tell you a little bit about the study and kind of get you scheduled. The nice thing about this, it means just one visit. We can get all the information we need, and then we send you with a diary, and you just report back 4 times a year what's happening to you. And this will allow us to study what happens over the next 5 years. And of course, we're hoping that, like Framingham, we'll be able to keep in touch with these individuals as they age.
That is so cool. I love those longitudinal studies. You got to be patient.
Yep.
You got to be kind. It sounds like life. But the data comes over a long period of time. We don't get it right away. But that's how we really learn so much about the natural progression of disease.
Yeah, it is a fun study from the standpoint. I don't usually enroll 25 to 35-year-old. My patients tend to be much older, but they're just happy to be part of this and contributing, which is so cool. And you know, we've had great help here from the community, from Juntos, our Latino center here that helps us recruit out to that population. So, of course, Castro, I love recruiting people that only speak Spanish. And so it's wonderful to have that diversity and have that representation of what the United States really is.
Well, you know, I think just to say it out loud, people forget that Kansas City, Kansas actually turns out to be a very diverse place. Yep. And because we have so many rural patients, that's actually also a really big deal, because we can mix both diversity from a racial ethnic standpoint and also a rural urban standpoint.
Yeah, I think rural health is going to be one of the most important things we're going to help address here in this next decade. And we know COVID showed us a lot of disparities in our rural counties and throughout the state and also Missouri. And so we got to do things to help our rural, our population that are in rural settings.
Yeah. All right. Thank you very much. Good luck on the enrollment. If you're interested, you saw the number on the screen. Maybe we can pop it right back up there. But it would be great for people to be a part of this. These things matter, and you're helping us to be part of this study is a really big deal. Dr. Castro, thank you for your leadership. Thanks for helping us do this study.
Thank you.
We'll see you. All right, joining me this morning is medical oncologist with the University of Cancer Center, Dr. Al-Ola Abdullah. How did I do with that?
That's right.
Ah, yeah, baby. It took me about 20 years, but that's okay. We're also glad to have Lester McKinzy joining us. Lester, what a tough, horrifying time for you. 1 minute you're walking and the next minute you're not. You went from being active and healthy to being wheelchair bound in a moment, all kind of at one point. Tell us a little bit about what you were feeling and when those symptoms started, what happened.
Yeah, so I want to first of all say thank you for allowing me to be here today and allowing me to share my story.
Thank you.
Yes. So this started, well, first off, I feel good. I feel fantastic right now.
Awesome.
But this started in June of 2023. And I remember it like it was yesterday. My wife and I were in Chicago celebrating my birthday, and we were just getting ready to do the architectural tour on the river. And,
which is a hoot.
Yeah.
A lot of fun.
And unfortunately for me, it wasn't fun that day.
It was not fun that day.
Because
that was a dumb thing for me to say, that's right.
Yes, I developed a chronic migraine headache that just kind of came out of nowhere. And I'm thinking that the headache is going to go away, but it lasted for several months.
Oh my!
That was the first symptom, and I did take ibuprofen to try to address it, and it was fine as long as I took the drugs. But once it wore off, the headache would come right back.
Okay.
And so maybe 6 weeks after that, I started developing numbness in my feet, and probably another 5 or 6 weeks. I ended up getting, I started having balancing issues. And I became concerned, and I went to my primary care physician, but they weren't able, and it wasn't KU, I just want to put that in there. But he was struggling a little bit to figure out what was wrong. They did lab work, but they couldn't come to a good conclusion of what might be the issue. Now, mind you, after the balancing issues occurred, I'm at work, in particular on a construction project, in maybe the middle of October of 2023.
Yep.
And I jumped off of this little 2-foot wall. It's just like what we call a knee wall or a pony wall, and I fell. And it felt very strange, and I never felt that before, and so it kind of scared me. And so at that point, I went back to my doctor, and I told him, like, you're going to have, I explained to him what happened, and he said, okay. He referred me to a neurologist, of which, again, not in KU yet, but I went to this person, and the first thing she said was, that sounds like multiple sclerosis. And I'm like, multiple sclerosis? Like, what is that? I've never even heard of that. You know, and mind you, I'd never been sick before, other than the occasional cold or the flu.
Yeah.
And so I'm just trying to process what she said, and she ended up getting some devices to check and see if that potentially was the case, and so that was ruled out. So from that point on, they did some blood work and determined through a CBC blood test that my vitamin B12 was extremely low.
Oh, wow. Okay.
She said she had never seen it that low before, and so they immediately got me on B12 injections. I did that again the middle of October, and from that point on, and I walked in there that day to get my first injection. But by the 15th of December, I went in, my health was still declining, and my wife was having to help me go in to get my injection at that point.
Yeah, that's crazy. That's not
so she, the neurologist saw that. She was very alarmed, and she said, B12 is not your issue. There's something else going on with your blood. And she said, you need to go to the emergency room right now. That was December the 15th. I checked in to KU on December the 18th, and that's when things changed. I met Dr. Abdallah at that time. I did not know he was Dr. Abdallah. I was very overwhelmed by all the physicians that were in the room.
We could do that to people.
Yeah.
It might be busy here.
So I was still trying to process, everything. I'm like, what's wrong with me? And so they were able to get me a room that day, and throughout that week, they did an extensive amount of blood testing. By the end of that week, they landed on what they call CIDP, chronic inflammatory demyelinating polyneuropathy, which I believe, and clearly he's an expert on this, that it has something to do with inflammation. Mm-hmm. So
you're an expert too, actually, as it turns out. Now that you've
I've learned a lot through this journey. But so I started getting the IVIG infusions, and after that, immediately went to KU acute rehab. Mm-hmm. Had started on PT and OT, but at the same time, things were still going in the wrong direction. And so I ended up going back back into the hospital after that, of which Dr. Abdallah wanted them to check specific things. And at that point, that's when they landed on the correct diagnosis when he got involved of Poem syndrome.
Okay, now somebody's going to have to tell us what that syndrome is, because I've been in medicine for a long time, approximately, and I don't remember what POEMS is. So I'm just going to tell you that we're going to have Dr. Abdullah here talk to us a little bit about what that means.
Yeah, absolutely. I mean, POEMS is a very rare cancer. It's a rare blood cancer. It's actually two out of 4.
So it is a cancer. What does POEMS stand for?
So POEMS is actually an acronym. P is for polyneuropathy, which is nerve involvement, as Lister have. O is organomegaly, which the liver, spleen, and sometimes lymph node could be enlarged. E is for the endocrinopathy, which is like it could be hormonal disturbance, like your testosterone could be low, thyroid function could be affected, adrenals could be impacted. M for the major one that's causing all the problem, the plasma cells produce an M protein. And the last one is S, is skin lesions or skin changes, like patients can have skin scarrings or thickening of the skin. So this is kind of an acronym to kind of describe what they have. So it's a rare syndrome, unfortunately. It's very difficult to diagnose, and as you can see from Lister's story, it's actually easier to misdiagnose initially because how it's closely look like other neuropathy issues.
It sounds like it does. And B12 is low, and you still have polyneuropathy. So.
Yeah.
So what do you do for this? What happens? What's the standard of treatment?
That's a great question. So actually, the POEMS actually is coming from the plasma cells in the bone marrow that Lister have, and it's a very small amount. These plasma cells are part of the white blood cells, produces some inflammatory proteins like the VEGF, or what called vascular endothelial growth factor. These things can actually cause capillary leaks, fluid overload, and they can also damage the nerves. So that's what happened to Mr. Lister. So what we do is that we focus on many things. First of all, we have to confirm the diagnosis, because we can't kind of proceed without the confirmation of diagnosis. We have to do several tests. Once we have that, we have to aim to kill these plasma cells with either direct antiplasma treatment using some immunotherapies or stem cell transplant. And also we have to focus on supportive care treatment. So we need to treat it before it causes more damages to patients like Lister. Sometimes we're lucky it's very localized, that radiation is more than enough, but most of the time it's a systemic disease that require more extensive treatment.
All right. So what is that treatment like? And because I think Lester here, you required a stem cell transplant.
Correct,
so.
yeah. So the major treatment for Lister, we started with some immunotherapy because he was, we were still in the process of trying to get the diagnosis, confirming it. Also, he was on a wheelchair. After we confirmed the diagnosis and we felt like he's very good to go for the transplant, we referred him for a bone marrow transplant for these patients. Stem cell transplant with this rare cancer is not really well studied, so the only bigger centers like KU do these transplants because it's a rare cancer, and you need a center that have a high volume for knowing that. Especially when patients are coming on a wheelchair, you want to make sure you give the right treatment for these patients. So the good thing about the stem cell transplant is that we use a high dose of chemotherapy, which will kill these plasma cells that is causing all this syndrome, and that will eradicate it. Of course, his stem cells that we harvest prior to that, we give it back to the patients like we do in myeloma and other cancers to do the rescue thing. So the major thing is that this treatment, if it's given in a right center, with the right supportive care, with the right resources, patients do really good with a great response for these patients, like what Lister had.
Okay, so Lester, you learned you needed a transplant. A, what do you think about that? And B, how are you?
I am doing fantastic. I was terrified at first.
I would be terrified. I'm terrified hearing the story.
Yeah, so when they first told me about it, my first question was, okay, what is this? And then I was like, well, is it gonna hurt? What are the long-term side effects of doing this? I did have family support, and that helped
Always
me.
a big deal.
That helped me with easing my my discomforts. But then at the same time too, I am a faith person, and so I put my trust in the Lord that I can get through this. So I had no idea what I was walking into, but at the same time, it was a road that it was essential that I travel. So I said, let's do it.
And today, are you walking? Are you in a wheelchair? Well, what's up?
I am walking. So we did the transplant, which the doctors will say is my new birthday, on November the 27th.
Okay, and I hope you do celebrate that day.
Yeah, so which is when they reinserted the stem cell back into my body.
Yeah.
I stayed at the hospital for about 12 days for them to watch me because I was immunocompromised entirely, white blood cells totally gone. After that, I went home, and I stayed home in a bubble for about 100 days. While I was at home, my wife, at the same time, I'm still in a power wheelchair. My wife did not allow me to stay in the chair. She got me out of the chair because Dr. Abdallah.
Get up and move, man, let's go.
Dr. Abdallah said, I don't want to see you, I want you to get out of that chair. So he was very motivated for me to do that, and all that encouragement and inspiration is what pushed me to keep going. So while I was at home in a bubble with no hair, by the way.
You look good. You wouldn't look like you. I look terrible. You probably look pretty good.
So she had me walking from the power chair on a walker, just back and forth to the front door from where I was, sitting most of the day. And so I was doing that for until about April, of which I had transitioned at that point to a manual chair, and I went back to therapy. And they started working with me rigorously to take advantage of what was occurring. So it took me approximately 6 months to go from after stem cell transplant to my therapist telling me, don't bring the wheelchair back.
I love that. Don't bring the wheelchair back. Those
Yes.
were glorious words.
Yes.
That's really, that is very moving, and I love that. And today, You're feeling good. And
Today,
you're going to the gym. Did you go to the gym this morning?
Not today,
Okay.
because we had this.
You're on, bro. Bring the wheelchair back.
I had to. I'm all about risk management, and
Yes,
I
sir.
said no, we can't go today. I don't want to take a chance.
Getting late.
So yes, but we do go 5 days a week,
That's awesome.
minimum. My wife is a gym rat, which is a blessing, and she goes very early in the morning, and so I started going with her around 4:30 a.m. and we usually stay about an hour and a half to 2 hours.
That's a long
I'm on the
time.
treadmill for the first 40 minutes.
Wow.
I'm up to about 3 miles an hour.
Okay.
And I'm at an incline of about 11%.
Oh, that's a pretty good incline, dude.
So yes, I've come a long way, and I've worked. I've figured out other ways on how to do different things, because I do have hand contracture.
Yes.
But there are other alternatives to be able to work my upper body and things like that.
Well, good for you. Congratulations on your recovery, and I hope it just keeps going and going and going, like the Energizer Bunny.
Well, one thing that I would say, I'm very thankful for my wife being there with me the whole time. She never turned her back. She never complained, and she had her job, and she just she just put her foot to the plow to help me because of the nerve damage being so severe in all four of my limbs, from my feet to the middle of my quads, and then from my fingers to the middle of my biceps. She literally had to become my hands and my feet.
Wow.
For every single thing.
She loves you, man.
She loves me very much, and I'm so grateful for her.
That is a great thing. Congratulations, and what a blessing. So, is this the normal recovery?
I mean, for him, we barely see that sometimes these patients have a reversible damage. And if we're lucky, we can, like Lister, we get them in transplant as soon as possible. The problem here is that sometimes our centers, when they receive these patients, it's kind of too late, because of the diagnosis and the misdiagnosis. As Lister say, it takes time for them until you get to the subspecialists who make the diagnosis. So we were lucky that he came to KU to make the right diagnosis.
Right.
We're also lucky that we have a very robust stem cell transplant center.
Oh, those guys do a lot of great work.
Because if I send Lister to do transplant in any centers, very small centers, they might not take him. So, and that really made a big change in getting him in what he is right now. So with his rare case, with the condition he had been, this is really impressive.
And so the plasma cells don't come back with the same disease after
That's a
transplant?
great question. It's a curable disease in 75% of the patients with transplant. That's why we use transplant, and we insist even with our treatment. So he's not on any continuous treatment, so we're hoping this is going to continue for a long period of time.
So what should have been the clue for people out there to say, hey, I need to see a super subspecialist, not just the normal folks? What do they... How do you get the clue to know?
I think that's a really great question, and I think Lister kind of pointed out the major thing. The commonest symptoms is the neuropathy that they have. If it continued to progress, I think going to a specialist, a neurologist specialist, is a very important thing. And I don't think it's going to be a bad idea to seek a second opinion if the condition get worse and worse and no improvement. Because I think that what happened to Lister is that, he got the first opinion, but things were getting worse. Second opinion is sometimes may actually kind of provoke there is other things that might cause rare syndromes that nobody saw it. And always sometimes a multidisciplinary team working with other specialists is always a great idea to help out to get the diagnosis very quickly.
I think one of the things that we're blessed by is having a neurology department with 75 or 80 neurologists in it.
Correct.
And so there are so many subspecialties that most places aren't able to do because you have that. We're one of the largest neurology departments in the country.
Correct.
And so it's a great thing. And I know our hematology oncology team is pretty darn top notch too.
Yeah.
We
Thank you.
appreciate you guys for that. Lester, there's both ringing the bell and I guess you banged a gong. Tell us about that.
I did, because it was very emotional for me.
Yes, sir.
To experience that, because again, going in, I had no idea what was happening. All I could do was hope for the best, to trust the process. And so when I got a chance to ring that gong, and I did some research on that, the importance of
I love the pictures of that. That's just so cool.
Of understanding that a transition has been made. It is a newer version of Lester, And so I'm going to ring that gong loud. And not only am I going to ring it loud, that's just a introduction to who I am now. I am okay with who I've become. I'm going to encounter new people, but that's okay. It's a wonderful opportunity to learn more about what the Lord has placed inside of me, how He's reshaping me, and how it can be a blessing to other people and encouragement. So ringing that gong was an introduction to the new Lester.
New Lester. I love that. You are a beautiful man. We need more people like Lester in our lives. Okay, we are here to answer your questions. Send them in using the links on your screen, YouTube, Facebook, or email the Medical News Network. But first, we're going to check in with Doc Hawk. Let's see the wing slap. There they go. Awesome. All right, so last week it was all about hantavirus. Now KDHE was taking that on, concerns have shifted away from hantavirus to what's going in the headlines is the Ebola crisis, and ultimately that may be the bigger story. Doc Hawk, talk to us about why it could be a worry.
Yeah, I mean, again, we are always in a battle, a war with the environment around us. These two things are one more example of that. You know, the hantavirus outbreak really seems to have been contained right now. Really, the only people we have seen positive are those people who are on the cruise ships. Again, that's from the best public data right now, public knowledge right now. But just as you said, the Ebola thing is much more concerning for morbidity, mortality, loss of human life, tragedy, all of that. We know that now suspected cases are up to 600. And there's over 130 deaths. So, you know, we have heard that this Ebola virus is not as fatal as the other Zaire, which is the more common. It can cause up to 70% fatality. But don't tell that to the people there on the ground who are unfortunately having to live and suffer through this. So certainly we know that this is a big issue. There are multiple problems, although the DRC, the Congo, has had multiple outbreaks. They are probably more knowledge and better equipped to handle as far as their experience in Ebola outbreaks, but unfortunately there are a lot of other issues. Number one, just the terrain. It is right now where that outbreak is centered is just far away from Kampala, which is the capital. It is hard to get to. Roads, all of those things make it very difficult to go through there. There's also, I think, a lot of geopolitical violence going on. And unfortunately, now people are moving out of those areas because they are concerned about their own safety. So they are moving into other countries. We know that there are at least 2 suspected cases in Uganda that have moved. One of those has died. So it could certainly be a significant problem. Couple that with the fact that really you are one plane flight away from anywhere in the world. We are now a global world, and it is easy to get from one place to another. So there is that concern as well, spreading to other countries also.
So it has been a challenge, but a 25% mortality rate is still really high for an infectious disease.
Horrible, yeah. Yeah.
So now, how is Ebola spread, and what can people do to protect themselves?
Yeah, so I think that's a good question. So first of all, it is not like influenza or measles. You know, measles, we say airborne, can hang in the air in that space for even 2 hours after you move out of it. Even for hantavirus, there's probably some aerosol and probably some mild or small airborne transmission of that. That's why we saw what happened on the cruise ship. With Ebola, it is really more of the body fluids, whether that is saliva, blood, respiratory secretions themselves, urine. All of those things can spread the disease. And unfortunately, when you have what happens in this disease, this viral hemorrhagic fever, where you just have an immune function that is dysregulated, out of control. You have a lot of problems internally and externally with bleeding. You have a lot of body fluids that are around in those areas where those patients may be. It is very easy to pick those up and kind of transfer them from one person to another. That's why it is so important to have adequate PPE and places to care for these people. Yeah. So again, it is very difficult to transfer as far as it's not respiratory, but if there are fluids around, it is easy. And we can see here on this video, this is some of the PPE that we use Used it a little bit when we had those observation patients here at KU recently, but this is meant to really cover everybody, protect everybody, especially in their eyes, their nose, their mouth, so they're not getting any splashes of any fluids as well. But it can be very dangerous.
I remember rounding on one of those patients, and it takes you about 20 minutes to get ready, and it takes you about 20 minutes to get out. So, because you have to go through all the decontainment processes, and some of the pictures you see coming from international, sure, most people just have on a yellow gown, gloves, and a mask, and that's what's available. And so, I know that can help reduce the spread. We tend to have a little more material here, so. Yeah,
you know, and that is another tragedy we haven't even talked about. You know, a lot of poor funding going around for one reason or another. We know that I think in the last Ebola outbreak, the United States helped provide at least $11 million. We know that the African CDC for this outbreak has pledged to mobilize something like $1 or $2 million, not a significant amount compared to previous funding. So certainly we know that funding and resources are a major problem. It doesn't have to be like that. Right now there are multiple hills to climb, mountains to climb to get over that, really just to provide protection for everybody, because it has to start local, because just as we said, within one plane flight you can have problems other places. We are now a global society. We need to continue to help people around the world, because it will come to our shores and our borders. These viruses, these infections really don't care or have any compunction about borders or anything of that nature. So we really are in a singular fight as a species, as a race, against the world around us, and we really need to act like that.
Yeah. You know, we said that during COVID a lot. It doesn't matter if you're a blue state, a red state, Republican, Democrat, Martian, it didn't matter. You know, we were all at risk, and I think that's how these crises work. Hantavirus was contained here because our public health agencies had enough resources to handle that, and KDHE did a great job. We were able to work closely with them. But the reality is that when you look across what's happened in the globe, so many of these international programs have been cut from the U.S. budget. Whereas we were the world leader in helping other countries, that is no longer the case, and we see that coming unglued. And this has gone on a little longer than it needed to. It popped the news finally, and now there's more worldwide attention. But the reality, it had been going on for a while before it broke through. And you know, we just, the fact is, and you said it very well, we do live in a global world, and we forget that viruses and infections and weather don't care what country you're in. So, all right, we know that many of you have questions. We're going to head now to Studio B with Alexis. Alexis, tell Sid, how the heck are you?
We have a great question from Jeremy Yenser. Jeremy wants to ask more about the second opinion. He wants to know, how would you need to ask for a second opinion? It makes sense to me if your doctor says something like, we're not equipped for this. But if the doctor seems confident and seems to have answers, what should clue a patient in that you need to get a second opinion?
You know, Dr. Abdullah, you and I probably do this a lot. I get a lot of second opinions. You get a lot of second opinions. I think it begins with, if you as a patient, and like in Lester's case, are not getting better, you have doubt, you don't need anybody's permission to get a second opinion.
Absolutely.
You can go do that on your own.
Absolutely. And this is a good thing about the health system, is it's more, we see, I mean, we have a great relationship with our community oncologists and a lot of physicians, and I think KU Health System is doing a great job by outreaching. But also we have patients also have great access to, if they feel like they need a second opinion. We have recently seen patients coming from other states, Oklahoma, Arkansas, for a second opinion. And I think that's something that we're, you know, knowing that patients, if they feel like, you know, they want more comfort, more, you know, specific questions to be answered, they come to KU Health System for that. So I think that's a good thing about that.
Yeah, no, I think that's exactly right. And remember, you don't need permission to get a second opinion.
Correct.
You can decide to do that on your own. You can ask your physician about, well, do you think I should get a second opinion? This doesn't feel like things are going quite right. And even, and hopefully the physician will be accepting of that. And most of us are, I think. Yeah. But sometimes when you're not, you can still say, you know, I think I'm still going to go do that. And don't worry about offending anybody. The reality is you will still be able to get care. And And we want people to feel like they can go do that. In fact, we have a number with these navigators who will help you in the Cancer Center, for example, handle that, and we'll get people in. Alexis?
We have one more question. Just came in from Ruth Allen, one of our loyal viewers. Ruth wants to know, what's the criteria for stem cell transplants in regards to using your own or needing a donor?
That's a great question. I mean, for the disease that we treat, like multiple myeloma and lymphomas, we use your own. You know, some other cancers, blood cancers, we use their, donors, which is like leukemia. We still do that. In the past, multiple myeloma and maybe POEMS, they rarely use donors, but they saw there is a lot of side effects. Their mortality was a little bit higher. So with the criteria now is that these patients with some plasma cell disorders like what Lister have and myeloma and anything related to that, we use their own stem cells in that regard.
Yeah, that's a great question. All right, what an amazing discussion today. We've jumped from the lung health study to POEMS, which is, again, I've been in medicine a long time. I wasn't familiar with it. And hantavirus and Ebola, and back to POEMS, and holy cow, what a day. I am grateful for all of our guests for being here, and I want to hear some final thoughts before we go. Lester, I'm going to start with you. You are incredibly, I mean, you just have these beautiful words, and you can tell you have the spirit. So talk to us a little bit about your final thought today.
So I gave that some thought, and I landed on there is life after trauma. There's life after trauma. And I say that because, you know, when we're going through, whether it's physical and the mental aspect of it comes along with the physical trauma. So you have to overcome both of them.
Yes, sir.
And so I think it's important, you know, one, that you trust the Lord. You trust the process by listening to your doctors, listening to your therapists. I had some awesome therapists over at Ability KC. Molly Fiorentino, Abby Erickson, and Dr. Lisa Staub, who was in charge of the small group that helped me accept my condition. Because once I accepted it, my mindset shifted. Not that, you know, acceptance that I want to be this way, but I started looking at it from a positive standpoint. And then at that point, I could see light at the end of the tunnel. So from there, I've been getting better because I'm dedicated to working hard, trusting and doing what Dr. Adala tells me to do. And now my wife and I are traveling. We just came back from Costa Rica.
Oh, that's awesome.
And hung out on the beach, and we're doing everything that someone who doesn't have impairments is able to do. And we're going to continue to travel and have fun, and we have another cruise scheduled for December.
Be careful with that cruise, would you? I'm learning about all those infectious diseases out there. You just be careful with that now.
Yes.
Lester, thank you. That was great. Dr. Abdullah.
I think, you know, I mean, as you say, Dr. Stites, second opinion, you don't have to take anybody's permission for doing that.
Yeah, it's not a privilege, it's a right.
Yeah, exactly. And I think that's one of the things that, you know, Lister, he was actually seeking for that. And we encourage patients, like, if you feel like, you know, you need to be seen by a second opinion, it's not, you know, it's the right thing to do. I think that's the best, you know, statement that we need to make today.
Yeah, I think that's exactly right. Hawk?
Yeah, great discussion, great story. Continue your recovery, do everything you're doing. And as far as other updates on everything that's going on, hopefully nothing else will rear its ugly head, but we will keep you updated with our local environment and, of course, the global and international environment as well.
All right. Excellent. Now let's go back to Alexis Del Cid for a look at tomorrow's All Things Heart. Alexis.
Thank you, Dr. Stites. We have a great show tomorrow on All Things Heart. We're talking about daily chest pain, but it's not a heart attack. It's something called angina. We will explain how a tiny device small enough just to hold between your fingers could change how doctors treat this condition. That's tomorrow morning on All Things Heart.
All right. Thanks again to all of our guests. Here's my final thought for the day. Listen to Lester. He's the man. And if you need a little hope and humanity, it sits right here to my right. And to our audience, remember what we always say, faith, hope, and science. It's a good path forward. We'll talk to you soon.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.